Good evening. Welcome to the Hemophilia Federation of America's Blood Brotherhood Program webinar series. Thank you for joining us tonight. My name is Lauren Nybert, HFA's Programs Director. Also on the line tonight, we have HFA's Program Coordinator, Martha Boria. Before we get started, we'd like to go over a few helpful webinar tips. Tonight's webinar will last approximately 1 hour. We certainly welcome your participation and questions during the webinar. However, your audio will be muted during the entirety of the webinar as this helps limit background noise that may disrupt the presentation. If you have a question, we encourage you to type a question in the question box located at the bottom of your control panel. I will then pass your questions along to our speaker. HFA would also like to thank Shire, CVS Specialty, as well as CDC Collaborative Partners for their support of HFA's Blood Brotherhood program. They help make these educational webinars possible. Tonight's presentation is a CDC Inhibitor update. This educational webinar will provide an overview of the vital role of the CDC in understanding and preventing inhibitors. Participants will learn about the CDC's Hemophilia Inhibitor Research Study and its key findings. Participants will also learn how those key findings, including improved methods to test for inhibitors, were used to develop Community Counts, CDC's Registry for Bleeding Disorders Surveillance. Tonight's presentation will be led by Fiona Bethea of the CDC. Fiona received her Bachelor of Science degree on Neuroscience and Behavioral Biology and her Master's of Public Health and Global Health, Community Health, and Development from Emory University. She is currently a PhD candidate in epidemiology. She joined the Centers for Disease Control and Prevention in August 2007 as a fellow with the Experimental Pathology and Immunology branch of the Division of Viral Hepatitis. In August 2009, she joined the Epidemiology and Surveillance branch of the Division of Blood Disorders, where she served as the project coordinator and technical advisor for the Hemophilia Inhibitor Research Study. Ms. Bethea is the liaison with the division laboratory where she compiles and interprets laboratory results and disseminates viral and inhibitor reports for Community Count Surveillance projects. Since 2016, she has overseen and monitored the progress of health promotion cooperative agreements awarded to Hemophilia Federation of America and National Hemophilia Foundation. Ms. Bethea has been privileged to serve this community and contribute to the scientific evidence base to help prevent and reduce complications of bleeding disorders. So before we get going with Fiona's presentation, we want to launch a few poll questions just to kind of get a read of the audience. So I'm going to do the first one here. So just go ahead and answer. It should be a pop-up on your screen momentarily. And the first one is, do you have a bleeding disorder? Yes or no, I'm an immediate family member of a person with a bleeding disorder, or no, I'm an extended family member of a person with a bleeding disorder, or other. Just go ahead and answer that. I'll give it just a couple more seconds. All right, share the results here. So it looks like we have lots of immediate family members with bleeding disorder and others. So I'm going to go into the next poll question. What is you or your child's bleeding disorder diagnosis? So hemophilia A, hemophilia B, von Willebrand's, or other? Just go ahead and answer that question. Give it a couple more seconds here. All right, I'll share those results with you. So it looks about half hemophilia A and then other. All right, going into our next question. Have you or your child ever been diagnosed with an inhibitor? Yes, no, or unknown? Give that just a couple more seconds. and then I'll share those results with you all. So it looks like a split of yes, no, and unknown. All right, let's go to the next question. Has someone from your HTC talked to you about participating in CDC Surveillance Project Community Count? Yes, no, or unknown? Let's give that a few more seconds. All right. And again, looks like a mixed, pretty split down there of yes, no, and unknown as responses. All right, and then let's go into the next question here. Do you or your child currently participate in community count? Yes, no, or unknown? So go ahead and answer that. Okay, I'll share those with you. It looks like yes, 25%, no, 25%, and 50% unknown. All right. Go to the next question here. Just a few knowledge questions here to get a read of the audience. So who is at risk for developing an inhibitor? People with a diagnosed venous thromboembolism, people with hemophilia A, hemophilia B, and von Willebrand's type 3, people who treat with Amicar or other non-infused products, or none of the above, or all of the above. Go ahead and answer that one. And then we have one more question after this. Okay, share those results with you all. So it looks like 60% said people with hemophilia A, hemophilia B, and von Willebrand's type 3, and then 40% said all of the above. Right. And then the last question here before we turn it over to Fiona. How often should you get tested for an inhibitor? Annually, every 5 years, every 10 years, or never? Give that a few more seconds for you to respond. All right, and it looks like 100% of you said annually. Okay, all right, Fiona, I will turn it over to you.
Okay, good evening, everyone. So today I'm going to talk about, just go over what an inhibitor is, what the history, the clinical history and public health information on inhibitor testing and barriers to inhibitor testing in the past, some types of inhibitors and test results, and then talk about the CDC inhibitor research that we've done with the Hemophilia Inhibitor Research Study, or HERS. Then go into CDC's public health surveillance, which is called the Community Counts Registry for Bleeding Disorder Surveillance. And finally, talk about what we hope to learn for the future. So what is an inhibitor? Inhibitors are a type of antibody. So antibodies are a protein in the blood that's made by a person's immune system to attack intruders and substances that aren't recognized as being a normal part of the body, such as bacteria and viruses. The body makes thousands of different types of antibodies, and not all antibodies are the same or do the same thing. So inhibitors are a specific type of antibody made by the body directed against the infused treatment product or clotting factor replacement therapy used to treat or prevent bleeding episodes. When a person develops an inhibitor, his or her body attacks the clotting factor so it doesn't work as well to stop bleeding. So what is the history of inhibitor testing? Well, inhibitors have actually been around and known about for a very long time. In 1959, the first inhibitor measurement assay was proposed. Then in 1975, the Bethesda assay was developed with an established measurement called the Bethesda unit, or BU. In 1995, a group of scientists got together and modified the Bethesda assay, calling it the Nijmegen Bethesda assay. It's more sensitive and specific, and the measurement used for that method is called the Nijmegen Bethesda unit, or NBU. This was the recommended gold standard for inhibitor testing by the International Society on Thrombosis and Hemostasis, or ISTH, in 1998. This is important because if all laboratories are using the same assay to test for an inhibitor, this is beneficial. This is also called method standardization, and it allows you to compare results between laboratories if they're using the same method. So if inhibitors have been known for over 60 years, and there have been methods to test for them for so long, what are the barriers? Well, with the Nijmegen Bethesda assay, everyone at risk for developing an inhibitor could not be tested. So that test could not be used if the person hasn't been used within the previous 24 hours. So with the advent of prophylaxis, or if someone who treats a bleed before visiting their hemophilia treatment center, those people could not be tested. In addition, not every lab followed the ISTH recommendation to use the Nijmegen Bethesda assay method as published. In 2012, the North American Specialized Coagulation Laboratory Association performed a survey of labs and their inhibitor testing methods. They found that 10% of labs in North America used the older Bethesda assay, 20% used the recommended Nijmegen Bethesda assay, and 70% of labs use different versions combining the Nijmegen with the Bethesda assay. Now, if you're using different types of materials, if you're combining the methods in different ways, you no longer have standardization. So inhibitor results with different methods, there's no way to compare the results from Lab X, which uses one version of the Nijmegen Bethesda assay, with the results of Lab Y, if they use a different version of the Nijmegen Bethesda assay. In this scenario, a 2.5 unit inhibitor in Lab X is not the same as a 2.5 unit inhibitor in Lab Y. Additionally, a value that's considered a positive test in Lab X may actually be a negative test in Lab Y if they're not using the exact same method. So if Lab X positive values are 0.5 or greater, and Lab Y has positive values that are 1.0 and greater, then a person with a value of 0.8 units would have a positive inhibitor test in Lab X and a negative inhibitor test in Lab Y. That makes things very confusing. So essentially, there's no way to compare apples and oranges, even if they're both fruit. Another question was everyone getting tested regularly? So we looked at data from the Universal Data Collection System, UDC, from 2006 through 2010 at 131 HTCs. And that showed that the proportion of people tested actually ranged from 0 to 100%. If you look at this graph, you can see, and these aren't the HTC numbers, it's just a random assortment, but some people were getting tested none of the time, and some people were getting tested 100%. This suggests that people were tested for inhibitors differently depending on the HTC they attended. People at some HTCs were never tested at their annual visit, while others were tested every time. So on average, 1 out of every 2 people who visited an HTC in the United States were tested for an inhibitor. Now, we have heard some anecdotal evidence that some people may have refused inhibitor testing because of the cost, or potentially because of the lack of insurance reimbursement. But it's clear that people were not being tested 100% of the time at their annual visit. So what are inhibitors and what are test results, different types? What does a positive test result mean? Well, diagnosis of an inhibitor is a clinical decision. Inhibitor test results provide information to help make that clinical decision. Currently, one positive inhibitor test, especially a low titer inhibitor, one that's less than 2 units, can't predict the clinical impact on a person's life. A positive inhibitor test could be due to a clinically significant inhibitor, a transient inhibitor, or a false positive lab result. So what are the difference between those 3 different types of results? Well, some people will test positive for an inhibitor. Their factor treatment will stop working, making it more difficult to stop a bleeding episode, and they will require special inhibitor treatment. This could be a clinically significant inhibitor. The inhibitor is impacting them clinically. Some people will test positive for an inhibitor. Their value will usually be low titer, less than 2 units. Their factor treatment will continue to work, stopping and preventing bleeding episodes. And after a few months, the test results will become negative without any special inhibitor treatment. These could be transient inhibitors, meaning they go away after a while without any kind of actual treatment to them. And some people will have one positive test result. Their value will usually be low titer again, and every inhibitor test after that will be negative. Their factor treatment will continue to work, stopping and preventing bleeding episodes. This could be a false positive test result and not actually an inhibitor. So what can cause false positive test results? Well, it can be due to the following. Heparin, which can be introduced to the blood specimen with a heparin flash venous access devices through a peripheral line, central line, or port. Lupus anticoagulants. Now, these are a type of antibody that prevents blood from clotting in test tubes, but it doesn't prevent it from clotting in humans. It's relatively common in people with hemophilia, but it does not stop their treatment from working because the antibody isn't directed at infused clotting factor. Remember, there's lots of different types of antibodies. This one does not affect treatment. And then nonspecific inhibitors. Nonspecific inhibitor antibodies to coagulation occur in people with hemophilia and those without hemophilia. These types of inhibitors can attach to the infused clotting factor, but they don't actually affect the coagulation or the ability of the blood to clot in a person. These all act like clotting factor inhibitors in the assay, causing false positive test results. One study found that false positives could occur in approximately 1 in 3 test results with the standard 9-megabethesda assay, and false positive test results are typically low titer, less than 2 units. So what research has the CDC done? Well, from 2006 through 2012, the CDC performed the Hemophilia Inhibitor Research Study, or HERS, as a public-private partnership through funding provided by a grant from Pfizer and Baxter Healthcare. The purpose was to determine the feasibility of using a public health surveillance system, like the UDC, to collect key information about inhibitors. Some of the methods included centralized inhibitor testing at CDC, monthly collection of infusion records from participants, and follow-up of newly identified cases of people with an inhibitor. We enrolled over 1,200 participants from 17 HTCs. One of the key findings in 2012 was that we modified the 9-megabethesda assay method to allow for inhibitor testing among individuals who had infused with clotting factor therapy within 24 hours. Remember, that was the first barrier that I mentioned. We added a heat treatment step to remove recently infused factor products from the blood during testing. This then allows people on prophylaxis and those with a treated bleed on their clinic visit day to be tested for inhibitors. And this is a snapshot of the article that we published. We also developed lab tests to help identify false positive test results. In 2014, we developed a fluorescence immunoassay, or FLE, to identify factor VIII inhibitors. This is a snapshot of that journal article. In 2016, we also developed a fluorescence immunoassay to to identify factor IX inhibitors. And there are additional laboratory tests that are available to help identify false positive test results and help identify inhibitors. There's the chromogenic assay, which was developed in 2002, which allows for inhibitor detection in the presence of lupus anticoagulant antibodies. Remember, those can cause false positives. There's also the dilute Russell's viper venom time assay. The venom of the Russell's viper contains a strong activator of factor X that, in the presence of other components in the blood, can cause blood clots. In individuals with lupus anticoagulants, the lupus anticoagulant binds to the components in the blood and prevents the venom from working as strongly, increasing the time until the blood clots form. So what do these tests measure? Well, the dilute Russell viper venom time, or DRVVT, is used to determine if there's lupus anticoagulant antibodies in the blood. If you have a negative test, those antibodies are absent, and if you have a positive test, those antibodies are present. The chromogenic assay is a functional assay like the Nijmegen-Bethesda assay, but it's more specific to factor VIII. It allows you to quantify the inhibitor titer level, but you do so in chromogenic Bethesda units, or CBUs. This assay is not influenced by lupus anticoagulants, heparin, or non-specific inhibitors. So you don't get the false positive results like you do with the Nijmegen-Bethesda assay. And then with the FLE, this measures the amount of antibody that binds factor VIII or factor IX on fluorescent beads. It's much more sensitive to factor VIII or factor IX than either the chromogenic or the Nijmegen. But it can't be used as a primary assay because you're not able to actually quantify the inhibitor level. This assay, again, is not influenced by lupus anticoagulants, heparin, or non-specific inhibitors. So one of the other findings that we had from the HER study was we looked at, over time, following patients, we looked to see who developed an inhibitor. And we found that inhibitors actually could develop in a wide range of people. Approximately 4 in 10 people, inhibitors developed in approximately 4 in 10 people who had moderate and mild hemophilia disease severity. So it's not just people with severe hemophilia. Inhibitors developed in approximately 4 in 10 people who were over 5 years old. So it's not just young babies. Inhibitors developed in approximately 2 in 10 people who had over 150 days of exposure to infused factor treatment. And we found inhibitors developed in 6 in 10 people who had no clinical symptoms when the inhibitor was detected. The finding from this was essentially that anyone with hemophilia A, hemophilia B, or von Willebrand disease type 3 can develop an inhibitor. So how do we use these findings and these test methods to inform surveillance? Well, it's important that inhibitor data collection occurs on all participants, those with and without a history of an inhibitor. Sometimes it's as important to get information on people who don't develop an inhibitor as it is on people who do. It's important to test for surveillance, to provide inhibitor testing for surveillance by routinely screening all individuals who could develop an inhibitor to facilitate early detection. Centralized testing at CDC assures consistent, accurate results across the country, and the additional testing performed at CDC minimizes false positive results. So with national inhibitor testing performed centrally at CDC with accurate measurement that can test everyone, helps with the following. It helps with clinical care, so assisting doctors and hematologists in the diagnosis of an inhibitor. It assists with timing for the initiation and completion of immune tolerance induction therapy for people who have a diagnosed inhibitor, and the assessment of population trends. So what have we done as public health surveillance? Well, what is surveillance for the bleeding disorder community? Public health surveillance is the ongoing, data collected over time, systematic collection, so data collected in the same way each time, analysis and interpretation of health-related data. Surveillance is needed for the planning, implementation, and evaluation of public health practice for people with bleeding disorders, and it's necessary for timely and evidence-based decision-making. Surveillance can directly measure what's going on in the population to determine the need for intervention and the impact of a specific intervention. For example, how many people in the United States have an inhibitor? So what is Community Counts? Community Counts is actually made up of 3 different projects: the Population Profile, the Registry for Bleeding Disorders Surveillance, and Mortality Reporting. Today, I'm just going to be talking to you about the Registry for Bleeding Disorders Surveillance. The Registry is a public health monitoring program for people with bleeding disorders, which began in December 2013. The purpose of the project is to gather and share information about common health issues and medical complications that affect people with bleeding disorders who receive care at over 130 HTCs. It's funded by CDC through a cooperative agreement with the American Thrombosis and Hemostasis Network, ATHN, in partnership with the U.S. Hemophilia Treatment Center Network. This work advances the work of the Universal Data Collection System, which ended in 2011. The registry collects detailed medical information on people with bleeding disorders who receive care at HTCs, including demographics, health status, bleeding disorder complications, treatment practices, laboratory data on inhibitors, and other medical conditions. The aim is to improve the medical care and health outcomes of people with hemophilia and other bleeding disorders. So information collected by the project will be used to monitor trends in bleeding disorders over time to contribute knowledge benefiting the bleeding disorders community. Complications such as the number of bleeding episodes, joint disease and pain, treatment practices such as inhibitor treatment, clotting factor usage, and hospitalizations. So what type of data is collected with community counts? Well, annually, inhibitor information that is collected from all participants includes their most recent inhibitor test date and results, if they have a history of a positive inhibitor test result, if they have a history of an inhibitor diagnosis, their current prescribed treatment regimen, and treatment products used in the last 12 months. Additional information that's collected on participants with a history of an inhibitor includes their highest historic inhibitor titer, the type of inhibitor treatment that they received or are receiving, such as the history of immune tolerance therapy and number of ITI courses, and the history of immune modulation therapy, and treatment products that are being used for bleeding events while the person has an inhibitor. While the data collection is going on, we're also providing inhibitor surveillance screening. So all people who enroll in community counts who are eligible receive free inhibitor testing. CDC provides the free inhibitor testing annually, as well as confirmation of central or local HTC positive test results. Eligibility for testing includes having infused with a clotting factor treatment product and having a diagnosis of hemophilia A, hemophilia B, or von Willebrand type 3. This allows all participants to get tested without financial concerns about healthcare costs or insurance reimbursement for inhibitor testing. So this is a diagram of the process. An HTC coordinator enrolls a person in community counts. If eligible for inhibitor testing, so if they've infused and they have hemophilia A, B, or BWD type 3, the coordinator takes a plasma specimen from the participant. They process the specimen and they ship it to CDC. They then complete the data forms. CDC receives the plasma specimen, and if the participant has hemophilia A or von Willebrand type 3, then factor VIII testing is performed. If the value is between the Nijmegen Bethesda assay is between 0.5 to 1.9 Nijmegen Bethesda units, then CDC performs the chromogenic assay, the fluoroimmunoassay, and DRVVT testing. If the participant has hemophilia B, then factor IX testing is performed. And if the value for that, for the 9-megabethesda assay for factor IX, is between 0.3 to 1.9 9-megabethesda units, then we perform the fluorescence immunoassay for factor IX. We typically send the reports back to the HTC within 2 weeks, and they receive the report for the participant and put it into their medical record. This is an example of what the inhibitor test report looks like for a community counts participant. In the top right corner, you see a CLIA number. The CLIA number means that our results are CLIA certified. CLIA certification means that the reports are approved to be used to help guide your clinical care. On the far left, there's an arrow that points to 1.2. That's the result for the CDC modified 9-megabethesda assay result. And then under the comments section, you see the results for the chromogenic, the fluorescence immunoassay, and the DRVVT results. All of these results combined help in the diagnosis of an inhibitor. So from December 2013 to February 2017, we've performed 11,850 CDC modified 9-megabethesda assays on 8,245 unique community counts participants. From that, 9,000 were factor VIII inhibitor tests for hemophilia A and von Willebrand type 3 participants. 2,221 were factor IX inhibitor tests for participants with hemophilia B. The majority of tests that we performed had negative results. If you look at the orange slice, that's that level less than 2 9-megabethesda units where the majority of false positive tests could happen, where we run the 3 additional tests to help make that determination. It's a very small piece of either pie. However, it's really important. So what happens with the positive test result? With the collection of the blood specimen for inhibitor testing, the HTC also collects data such as the manner of blood collection. Could heparin have gotten into the blood specimen? Does the participant ever had a history of an inhibitor? And what's the most recent inhibitor test date and result? Like I said, test results within the range of 0.5 and 1.9 9-megabethesda units for factor VIII testing and 0.3 and 1.6 9-megabethesda units for factor IX testing receive the additional test. If the participant has no history of an inhibitor and a positive test result, CDC requests a second blood specimen within 30 days. The reason that we request that second blood specimen is even with the additional tests, you always want to have a confirmatory blood specimen or one that's taken at a different time. If the second specimen is negative, then testing occurs at the participant's next annual HTC visit. If the second specimen is positive, CDC requests additional information and considers this a newly elevated titer. Or an incident case. What is an incident case? Well, for surveillance purposes, this is defined as 2 inhibitor-positive test results from blood specimens collected on different dates from the same participant who has no previous history of an inhibitor. What information is collected on an incident case? Well, we collect information on demographics, treatment product history, such as whether or not they'd had any product switches, their number of lifetime exposures to infused products, and medical history events in the previous 4 months. How many bleeds had they had a history of infection, etc. Information on potential factors that might increase the risk for inhibitors as well, such as genetic mutation, family history, or if the family had a history of inhibitors, and treatment product utilization from infusion logs, if available, during the previous 4 months. What do we hope to learn for the future? with this information? Well, CDC plans to use the inhibitor data and the inhibitor surveillance data from people with a history of inhibitors to establish the number of people in the United States with a newly diagnosed inhibitor, as well as the number of people in the United States with a history of an inhibitor. We also hope to describe the number of people with an inhibitor in the United States over time. So are interventions working to decrease the number of people who get diagnosed with an inhibitor and to predict the clinical impact of one inhibitor test? Like I said, right now, we can't determine from one test if someone will have a clinically significant inhibitor, a transient inhibitor, or if it's a false positive. So we want to find out what are the characteristics of people with transient inhibitors compared to clinically significant inhibitors. We also want to describe inhibitor treatment practices and average treatment duration. What are factors that are associated with successful treatment? We want to identify and evaluate potential inhibitor outbreaks, determine factors that might influence how inhibitors develop, and to do that, we have to follow people who develop an inhibitor and those who do not develop an inhibitor. And then finally, to establish how often inhibitors reoccur in people with previously treated inhibitors. So it's possible, if your inhibitor resolves, for it to come back 20 years later. But we don't know right now how often that happens. And it's to determine factors that influence who develops an inhibitor, it's important to be able to look at a very large group of people. We know that certain factor deficiencies, hemophilia, genetic mutations, severity of disease, family history of an inhibitor, all likely contribute to inhibitor development. However, if you look at the where genetic and product exposure come together, where genetic and immune response come together, and where product exposure and immune response come together, there's likely an overlap in there, where if you have this genetic mutation, this type of product exposure may put you over the top to develop an inhibitor. Or if you have this product exposure and this immune response, that may put you over the top. It may not just be one or the other. In order to evaluate that, you have to look at very large numbers of people. So what is our road to inhibitor prevention? Well, we are still evaluating the data from the epidemiologic and laboratory data from HERS. We're performing the national surveillance through community counts by providing regular screening and early detection of inhibitors, collecting information on all individuals' attributes, characteristics, or exposures that increase or do not increase their likelihood of getting or developing an inhibitor, leading to an increased understanding of inhibitors. We're also doing clinical and laboratory research, so we're constantly and continuously validating the CDC modified Nijmegen-Bethesda assay method with newly emerging treatment products. Community counts is also a source of data needed for research studies, where we provide data for input into how many people are needed to participate in a research study to answer the research question and identify eligible subpopulations. And from the information, we want to develop effective prevention strategies. So working with the medical and scientific community to use surveillance and research findings for prevention, identifying strategies to reduce inhibitor development and enhance the effectiveness of treatment for people with inhibitors by identifying high-risk populations for possible alternative early treatment and developing risk-based treatment algorithms. We also want to evaluate how well implemented prevention strategies work. All of this should hopefully advance clinical, epidemiologic, and health services research.
Okay, thank you, Fiona. I think we'll lead into our two other poll questions that we had for the audience before we leave lead into general questions from the audience. So I'm going to launch that now. So again, this question, who is at risk for developing an inhibitor? People with a diagnosed venous thromboembolism, people with hemophilia A, hemophilia B, and BWD type 3, people who treat with Amicar or other non-infused products, none of the above, or all of the above. Go ahead and put your answers in there. All right, share that with you. All right, it looks like 86% said people with hemophilia A, B, or VWD type 3. We'll close that. And the last one. So again, how often should you get tested for an inhibitor? Annually, every 5 years, every 10 years, or never? Go ahead and put your responses in there. All right, and it looks like 86% of you said annually. So thank you for completing those questions for us. So go ahead and type your questions into the question box, and then I can read them out loud to Fiona. So again, the question box is located in the bottom of your control panel. Just go ahead and type your questions in there, and then I will read them off to Fiona. So it looks like, Fiona, the first question that we've got is, what is the CDC stance on women having the ability to be diagnosed with inhibitors?
I don't think the CDC has a stance. If you're diagnosed with hemophilia A, hemophilia B, or von Willebrand type 3, and you receive infused factor clotting product, then you are at risk for an inhibitor.
Okay, thank you for that. Next question, did the HERS study find any key findings amongst the likelihood of inhibitors amongst different ethnic or racial groups?
So we currently are actually just completed, the information that I posted was about phase 1. We currently just completed phase 3 about a year ago, and where we collected additional information on individuals specifically who had a history of an inhibitor or did not, and were Caucasian, African American, or Caucasian with Hispanic ethnicity. That information is currently being analyzed for immune response, product exposure, and genetic history. So I don't have the information for you at the moment, but we did collect the data and we are analyzing it now.
Great, thank you. Next question, should there be inhibitor testing if there is an unusual bleeding pattern outside of annual testing?
If you believe that you might have an inhibitor, then yes, you should request an inhibitor test. Abnormal bleeding patterns could be a symptom of an inhibitor. So annual is really the minimum people should get tested. The European Medical Association actually recommends getting tested after every 5th infusion. That's not, quite as feasible here in the United States with prophylaxis. But yes, if you think something is funny, then I would definitely speak to your clinician about it and about getting tested for an inhibitor.
Okay, thank you. The next question that we have that has come in, and I apologize if I mispronounce, would a cytokine IL-10 TNF-alpha measurement be predictive of inhibitor development? Any studies on this?
So It's currently not predictive of inhibitor development. There have been retrospective studies of people who developed an inhibitor and people who did not develop an inhibitor, looking to see what the different levels are for IL-10 and TNF-alpha. With interleukin-10, the results are very varied. Some studies find something, other studies don't find anything. So it's difficult when you're looking at retrospective studies. Nothing is currently conclusive, but the cytokines are not predictive. No research has shown them to be predictive. They have been shown, some have been shown to be associated with inhibitor development, which is very different.
Okay, thank you. Another question that's come through, does the CDC have inhibitor treatment guidelines published for best practices to educate HTC providers?
We do not have best practices for inhibitor treatment at the moment. There is an inhibitor working group that we are working with the Medical Advisory Scientific Committee, and we are hoping to be able to better advise them through our surveillance findings. But it's important that people participate in surveillance so that we can look and see what were the characteristics of people who had the best outcomes.
Great, thank you. A follow-up question to the one that you answered just previously. Why were these cytokines selected specifically in this case?
I'm not sure what case you're referring to, but I can say that cytokines are a number of factors that are secreted by certain cells of the immune system and that have an effect on other types of cells. So a number of cytokines have been evaluated, TGF-beta, TNF-alpha, about 12 of the interleukins. This is because those are very common in the majority of people. And you're most likely, if there is a difference, you're most likely to find it in those specific cytokines. It kind of has to it gets into sample size and, your ability to detect a difference if one is truly there. But that's why people have looked at those immune response cytokines first.
Great. Next question that's come in. Are you aware of the CIPIT study, and what is your impression on those findings with respect to inhibitor development?
I am aware of the CIPIT study, but we typically don't, we CDC typically don't endorse or not endorse a research study.
Great, thank you. It looks like that is all of the questions that have come in at this time. While we wait, if there's any more that trickle in, I will just mention that this webinar is being recorded. So it will be up on HFA's website in the next week or so. It will be under HFA's resource library in the in the webinar section. Everyone that's on the webinar tonight will also receive an email the next day or so with the link that shows where you can eventually find that recording once it's available. So keep a lookout for that. But if you do have any questions, you can reply to the email that you get as well. So doesn't look like any other questions have come through. So thank you so much again, Fiona, for joining us this evening, and thank you all for taking the time out of your Thursday night to be here. And I see one more question that's come through, if you're okay with that, Fiona, if we take one more.
Yeah, of course.
All right, okay. So are there different risk factors for inhibitors in different populations? For example, PUF versus PTP?
it doesn't appear that there's different risk factors between previously untreated patients, PUPs, or previously treated patients. There may be, but again, with the sample size, no one's been able to really effectively look at that. Right now, the most definitive is that there is definitely, some people who have a genetic predisposition to developing inhibitor. Some people, a certain type of product exposure can push them into inhibitor development. With some people, it appears to be more of an immune response. And then with some people, it appears to be an amalgamation of, one or multiples of those factors. But no, there isn't really a clear delineation between, if previously untreated patients, it's just really one of those, or multiple, or previously treated patients either.
Okay, great. Is there a specific age beyond which one does not have a chance of inhibitor development?
No, unfortunately. It looks like age is actually not very predictive of inhibitor development. It is more of, how many exposures to product you've had. In the United States and Europe, we've actually seen many people in their 60s who are developing inhibitors who have mild disease severity. But it looks like it may be because, they've had mild disease severity their whole lives. By the time they reach 60, they hit some sort of threshold of product exposures, which prompts them to inhibitor development. So you do see it from very early on in life to very, very old or much later in life.
Okay.
But that could be due to product exposure, not age.
Okay. Another sort of demographic question, is there a difference in percentage of men versus women with respect to inhibitor development?
Yes. Unfortunately, the majority of research studies that have been done have only looked at men with hemophilia, and predominantly hemophilia A. To my knowledge, few research studies have included women, and the difficulty with that is because you have to get a certain number of people enrolled to be able to answer certain research questions. Like I said, to be able to detect a difference, if a difference is truly there. And it's difficult. The numbers of women who are actively using clotting factor and infusing with clotting factor, it's difficult to find those participants. So the majority of studies have looked at men. So it's unclear if there is a difference or not.
Okay. Is immunosuppression a cause for inhibitor development, and any studies on this? I am not aware of any studies on immunosuppression and inhibitor development. If you suppress, biologically, if you were to suppress the immune system, you make it inactive, and the immune system is actually where the inhibitor development comes from, or the inhibitor comes from. The immune system develops the antibody. So biologically, it would seem that if you're immunosuppressed, you're less likely to develop an antibody or an inhibitor because your immune system isn't functioning highly enough to make the antibody. But I'm not, that's a guess, really. I don't know of any studies that have looked into that. Okay. Well, thank you, Fiona, for answering those extra questions that came in. I think we will end there for tonight. So again, the recording of this is available will be available rather, on HFA's website in the resource library in the next week or so. And you'll be getting an email and the next day with the direct link to there. So thank you again for participating in tonight's webinar and for your great questions and engagement in the poll questions. And thank you, Fiona, for helping share with us tonight.
No, thank you to everyone who participated.
Great. Well, have a wonderful night, everyone. Thank you. Bye-bye.